be awesome if Gibson, our second discussant, and Jared, you there?
Jared's here with me.
Awesome. It could be awesome if we could get the 3 discussants on camera so that we can actually, like, you know, hear you guys' thoughts. So we've done a few of these. We'll start doing them a little more often. And really the idea is that we'll have a live resuscitation case. It's not about getting the right answer. It's just really about us hearing about what's going on in your guys' mind as you guys are trying to do this resuscitation live. Because I know everyone has their own style. Everyone's got their own experience, their own knowledge base. And so the beauty of this is that you're not working alone. You have a team of other experts with you. And then all I ask is that everyone else online that's not participating, you guys are welcome to contribute through the chat, which I'm keeping a track of. And now we can kind of share your thoughts or if you have additional questions as well. And once again, like, you know, I'm curious. I want to learn. I want to get better. And so I'm curious to see what the great Gibson has in his mind, what the amazing Alok has in his mind, and then what the, I don't have something that rhymes with J, but, or starts with J, but Jack of all trades, Jared, the jubilous Jared has in his mind. And so, you know, it's a chance for all of us to get better by learning from you guys. And then, you know, we'll kind of go through what, we'll have like 6 aliquots of information, and then we'll kind of present each one at a time. And then obviously share all the thoughts that you have with each aliquot, and we'll kind of give you a presentation of what actually happened in real time. And it doesn't necessarily mean it's the right answer, it's just what happened in this case. Do you guys have any questions before we get started?
I'm assuming you'll be prompting I'm assuming you'll be prompting whatever we're supposed to answer, how we're supposed to answer.
Yeah. I mean, just pay attention to the case, and then, all right. Yeah, we'll go from there. All right, Gibson, Jared, Alok, you guys ready?
Yeah.
Yep.
Awesome. All right, cool. I'm excited. So you guys are all on together, and your phone goes off, and there's a code blue. It's in, you know, probably around, you guys are all on night, so it's in the middle of the night, say around like 1 a.m. And you're heading there. As you're heading to the code, the nursing supervisor lets you know, oh, by the way, just so you know, she was actually here earlier. She came in for shortness of breath. She was just admitted today for what looks like a CHF exacerbation. Based on her initial exam, they diuresed her. They took her for a cath today, and she just had a stent placed in her LAD. And then apparently, you know, the interventional cardiologist told the team to go ahead and diurese. So that's what you guys have. As you guys are walking to that room, what is going through your head, and what are you preparing for as soon as you walk into the room? Gibson, why don't we go ahead and start with you?
So after hearing all of this, and I have a picture of this coded, so I'm probably like I approach every code the same way. I think one, ABCs, like I think you mentioned it too many times, cognitive offloading. So walking into a room, understanding the background of what has brought us here, and then going in, assessing right away, breathing. What do we have going on there? Circulation as well. And then, you know, more importantly, I think from my recent interaction is assigning roles right away in this code situation. Because I think when that doesn't happen, things go amok. So airway, breathing, circulation, getting access, IO versus whatever crash situation we could get there. Having RT, again, I say RT or someone experienced at the airway, not a nurse specifically, and then, you know, assigning roles, making sure I have a med nurse, someone to administer medication, 2 med nurses, 3 CPR, having my resident or my other physician, my other co-fellow in the team as well, playing a part, whether it's running the code or getting airway. But I think for me, hearing what has happened, I would start there, regardless of what the pre situation was.
Awesome, Gibson. I love it. You know, very, very impressed. You know, I agree with you. Cognitive offloading, right? So if you approach everything at the same time, you're going to be sure not to miss something. And for me, that's always ABC, IV, O2 monitor, making sure that as long as I follow that in the initial stages, everything else will be taken care of. Because there's nothing worse than having a diagnosis of why they arrested, and then not having an IV in place, right? Or not having them on a monitor. Alok, anything else to add?
Yeah, I guess just to build off of that, it's cardiac initially, right? So that's my first thing I'm gonna worry about. So obviously while they're resuscitating, I wanna make sure I'm gonna monitor and pulse checks if we have a pulse to see if this is like a VFib arrest versus PEA, in which case when we do have ROS, we can rush back to the OR or cath lab if need be. And then other things with him having a stent placed, I'm just worried about complications related to the procedure. So do we need to make sure there's no dissection, there's no tamponade, and then if there is, or make sure there's no sort of pneumothorax or hemothorax. So ultrasound is going to be key here. Let's see what else. And then we are diuresing, again, a cardiac patient, so I want to make sure all the electrolytes are optimized. So were there any electrolyte issues prior to all of this? Was the MAG super low? I don't know. So there's things I'm thinking about. And then probably during resuscitation, I'm going to be worried about their acid-base status. So for cardiac patients specifically, I tend to try and make sure that any sort of acid-base issue is appropriately corrected. So I'll probably be giving bicarb and or calcium and or MAG during this procedure.
Awesome. I like it. So, that's awesome. And it seems like you're kind of now starting to go through some of the reversible causes and making sure that all that's addressed. So you walk in, the patient's on a monitor, and, you see everyone doing what they're supposed to be doing appropriately. Someone's on the chest, respirators at the airway, bagging the patient. Jared, if you could maybe help us out, and, you're obviously more experienced than all of us. How do you approach, what's your internal algorithm based on your experience to go through those H's and T's as you see every cardiac arrest?
I mean, so with this one, I mean, it's like kind of like Gibson said, making sure A, you have access, B, you can always just bag them through it. I almost never jump straight towards intubation unless it sounds like it was a hypoxic arrest in general. I mean, with the H's and T's, for me, I always break it down into, is this some sort of obstructive shock or is this something else, right? And because like obstructive is always going to be tamponade, pneumothorax, or, is it one of the electrolyte things, which almost never is. And then the other thing is always, is it hypovolemia? So in this one, I would look at where the cath access site was, right? If they cath from the groin, then you can always have a massive RP bleed and they could have just bled out and that's why they arrested.
Awesome, I love it, right? So, when you talk about a general cardiac arrest where you don't have this history behind you, there's a lot of great protocols out there for you to address your majority of H's and T's. And, the idea of H's and T's, I think, is great at a med student level, maybe at a resident level, but I think at our level, we're way surpassed that, right? Because we know that each patient is unique and the patient's specific scenario actually matters. You're still going to go through and reverse all those causes, but this is not a straightforward cardiac arrest, right? There's a person with a significant cardiac history, which opens up very unique differentials and unique complications that are likely addressable. And so, and then when it comes to like utilizing ultrasound, there's a lot of great protocols out there. The most important thing is obviously not to interpret images while you have the probe on, is to really record those images so you minimize times of interruptions. So the protocols that I recommend, I'm sure you guys have already gone through them. There's like the CASA exam, there's the POCA-CA exam, which is like focused cardiac arrest exam. There's the cause exam, and all of them have kind of like the same protocols, which is to make sure that within each 2-minute interruption, you're scanning from a subcostal to look for effusion, to look at the IVC, lung sliding throughout, looking for hypovolemia and RV enlargement, as well as overall function. And then more recently, there's pretty good data that in patients who you are not able to capture VFib during on tele, you can capture it on ultrasound, and those patients do benefit from getting defibrillation and antiarrhythmics if you capture that's VFib on ultrasound. So that's awesome. That's really, really helpful. So in this case, you're doing the resuscitation. It's VFib, and it's really VFib. So you've shocked her a few times. You're doing amazing compressions, but you start to notice that as you're at the head of the airway, the nurse keeps stopping compressions. And she stops compressions because you see the patient waking up, opening her eyes, looking around, and you're starting to wonder where the patient truly lost their pulses. And so, the nurse stops the compressions, you see her looking around, talking, and then all of a sudden, while looking at you, she passes out again. You check for a pulse, there's no pulse, you obviously request that they restart compressions, and every time they restart compressions, even while you're trying to defibrillate, she continues to wake up and interrupt CPR. So, I don't know who here has ran into that scenario, but maybe you can start off with Gibson. What do you guys think about the scenario?
Can you say that? So the patient keeps waking up mid compressions,
Mm-hmm.
then essentially is out. You restart compressions, wakes back up.
Yeah, and you're doing compressions on a patient that is looking around, yelling at you, throwing her arms and legs in the air, telling you to stop.
Yeah.
And so, are you going to stop compressions?
If they are moving around enough to tell me to stop, yes, I will stop. If it is questionable, I'm not stopping.
What do you mean by questionable?
Like, it's like, oh, I think patient's moving a finger. Like, no, keep going. We will reassess that post-check.
Gibson, what do you think?
Yeah, I agree as well. And with this being said, this is when my ultrasound is going to be my friend during the moments where she does lose consciousness, because it's like she perfuses, then she's not perfusing. Like whether there's a tapenon physiology going on. I need more data. So I need the ultrasound. She needs an A line. We need more basically, because doesn't make sense for that to be your typical CPR. You can't. Yeah, something's odd, and we need more data, and more data meaning a bedside POCUS during, especially the POCUS echocardiogram, and she needs an A-line stat during CPR. That has never happened to me, but either we're not assessing, or the pulses aren't strong enough for us to palpate, or something else is going on. That's what that tells me, and I need to address that somehow, some way.
So I'm going to challenge, before Jared, before I have you chime in. So Alok and Gibson, what I'm trying to do is I'm going to challenge kind of what you guys said, right? Is that you have a patient in front of you that the nurse is adamant that she loses pulses. When you guys stop CPR and she becomes unconscious, you do not feel a pulse, right? But every time you start CPR, she starts to wake up and she is yelling at you, telling you to stop, and you can tell that she's in a crazy amount of pain because you've shocked her, and you are actually, putting pads on her, charging it to 200 because it shows VFib, and then you're saying go ahead and shock her, and you put the hands off the chest, and I'm putting you in that scenario right now. You've been doing the nurse has been doing compressions, you put the pads on to shock because it's VFib, you've charged it to 200, and she is yelling at you, stop. The machine is charged. Everyone is looking at you as the head of the resuscitation, and she is awake. You stop compression, she's awake, yelling at you. Are you going to go ahead and shock?
It's definitely showing VFib.
Yeah.
I would shock.
Yeah, me too. Like there's like clear indications. VFib, VTAC. I'm happy she's awake and all, but I do not have time to push amio and hope it works in time. I
think I would
probably.
delay.
Yeah, I would. Yeah, I would definitely shock.
All right. So as you make that decision, she obviously loses consciousness again. She doesn't have a pulse. You tell them to get back on the chest. You shocked. Jared, what are your thoughts on all this?
I would intubate her.
How are you going to do that?
With the glide scope, Uday.
No, as in, are you going to push our assignments?
So I mean, right, like you're doing. So what happens, right? She's in refractory VFib. Every time you used to get on her chest, you're perfusing her brain, because now it doesn't matter that she has a disorganized rhythm, right? You're just manually pumping blood to the brain, so she's perfusing, right? So now it's like really one of those things of I would literally give like a big slug of ketamine. Or you could do etomidate, you could RSI it, like you could etomidate and rock it if you wanted to. Somebody else is going to have to do it, like while you're running the resuscitation. But like at this point, my opt would most likely to be generous and give her something like, I mean, depending upon her weight, like 150 or almost 200 of ketamine, and intubate her while we're undergoing like chest compressions. And then, to be honest with you, if she remained in refractory VFib, I would change my pad placement, right? And then after that, like it might be one of those instances where if you are able to shock her out of the VFib, then it may just be that she's in like a pseudo PEA state where the blood pressure is just too low for you to actually palpate, but she may actually have a pulse. But like also with this, like I'm not like I know the ACLS algorithm says to shock like multiple times before you start giving medicine, but like this is where I'm giving like dead dose amio and like 100 of lidocaine, and I'm not really waiting to see if it breaks the rhythm or not. Like the answer is perfuse the brain, perfuse the organs with chest compressions, shock when you can, but like I'm pretty much pushing meds too. But like the humanistic thing is to intubate this lady, or maybe you don't even have to intubate her, but you need to give her sedatives.
Yeah.
So your thought process is just breaking that sympathetic surge.
I mean, it could be. I mean, easily could be breaking the sympathetic surge for the VFib, but like my guess is she's in VFib for another reason. I mean, she just had a stent placed. The stent probably went down, or it probably wasn't VTAC to begin with, and it was accelerated intraventricular like rhythm, and we treated it as VTAC, and we induced VFib. So like I don't exactly know which one was which, but the answer would be is as long as she's awake and her catecholamines are surging, you're never going to break that VFib.
Sure.
But also really, really amazing point. So, as pointed out in the chat, as few of us have unfortunately had this experience. I unfortunately had this experience 3 times during fellowship, and every one of these scenarios has never been pretty. It's a really unfortunate scenario. And when you look at the literature, this actually has been described pretty often. It's called CPR-induced consciousness, or CPRIC. And the idea here is that patients will exhibit signs of consciousness like verbal communication, eye opening, or movement during CPR. And it's rare, but now it's becoming more and more reported as people start to see it, especially in hospital, because you're seeing really good CPR technique. And what this means is like, it's I think a very ethically and practically challenging scenario, because you have a patient that you're actively performing chest compressions on, trying to defibrillate, but she's interfering with the CPR. And so the idea here, based on expert opinion, has been pretty well described. The idea is that your CPR is so good that you're generating really good cerebral perfusion pressures to restore that level of consciousness despite the overall state of the cardiac arrest. And the moment you stop those compressions because the patient is waking up, they pass out again because you are now no longer having that blood flow. So this is a person that shows clear evidence that when you are doing chest compressions, you are perfusing the brain. The problem for us is that we really don't have any clear protocols to address CPRIC, and it can cause interruptions. Like just in this case, as it was doing initially, it was causing interruptions in CPR because the nurse was being traumatized by trying to do chest compressions on an awake patient, and it's going to overall affect your resuscitation quality. So there's a lot of different expert opinions, and I've attended a panel of discussion on Twitter once a couple of years ago. It was very, very insightful. It just happened around the same time I saw it, and most of them recommend exactly what Jared is recommending, is to take away the patient's ability at this point, because they are interrupting good quality CPR. And so sedation, paralysis, sometimes even not doing anything depending on the spectrum of actions that they have. And I definitely think this is something that overall newer intensivists, now that we are aware that this is something that happens, should get kind of trained on this and at least exposed to it, so that they are prepared for this. Because it is definitely a thing. There are papers out there on it, and you should definitely add that or incorporate your protocol. And just like Jared said, the overall recommendation from a consensus of experts is that the best drug to use this in this case is ketamine, because you sedate the patient, minimize hemodynamic effects, especially for the ones who you are very confident that there's a chance of saving, right? Especially these cardiac patients. So once again, CPRIC, I can send you guys the paper, but it's a very difficult thing to deal with, and there is nothing wrong with telling people to push ketamine or push another sedation agent or restraints to try and continue high quality CPR while you can address the underlying cause.
Jared, are you jumping straight to like 100, 150 of ketamine? Are you like doing small doses?
Yeah, to step out to talk to a patient.
Do you?
Yeah, I mean, so the few times I've done it, I've done 100 of ketamine.
Just straight, okay.
And I actually haven't had it intubated. I put an LMA in because at this point, like,
Sure.
My focus is on, I have persistent VFib, and that's what I really need to address. So She's in VFib, right? You've been going on for about 6 minutes. You've gone ahead and pushed some sedation. You've shocked her 3 times. You've given 2 of epi, 300 of amio, 150 of another 150 of amio and bicarb. There's no labs from today because she went to the cath lab. They're pending. And you know, the last ones from yesterday looked fine. What is your approach right now, right? You're approaching that your fourth, you finish your 3rd round of defibrillation, your 3rd pulse check. She's still in what's clearly obviously VFib. What's your next approach? VFib or VTAC? What's your approach now? What are you guys going to start doing?
Wanna go, Gibson? You want me to?
Yeah, at this point, I guess based on the, I'm still following like the algorithm. So like right, I forget. So I think the max you can go depending on which VFib it is like 300, 360. But I think I agree with Jared. At this point, it's probably I need an antiarrhythmic on for sure. I'm not gaining any ground. I need an antiarrhythmic, whether it's lidocaine or amio, on board while I continue to take control of this VTAC VFib. It's almost like VT storm, to be honest. But yeah, meds now for sure, and continuing resuscitative efforts.
Yeah, I think I would definitely, if this is still happening, I would jump straight to lidocaine, and then obviously I'm just gonna empirically give lights, calcium, mag, and I think the defibrillation amount, like, I mean, are we like, I guess, is it never working? Like, do we defibrillate, we get something and then we lose it, or is it just never capturing?
So I mean, this is just the art of CPR, right? I mean, good CPR. When you defibrillate, are you stopping and checking for a pulse?
Right. What I'm saying is afterwards, we've gotten 0 ROS whatsoever. Yeah. Okay. So I mean, I think you can raise it to 360, but that recommendation is with the old defibrillators.
The
monophasic.
Yeah, you don't
right now, all of them are pretty sure biphasic.
Yeah, you don't need to deal with the biphasic.
It doesn't really matter. I mean, like Uday has done before, you could try the dual sequence defibrillation. You can attach another pad in the interim as well. But yeah, I mean, at this point, I mean, we're 6 minutes in, it's VFib arrest. I'm going to be thinking about eCPR. So I would definitely reach out to whatever resources we have. And as long as we have resuscitationists and other hands on board, like maybe anesthesia's there to manage the airway, and you have an IO for, and that's ready for meds, I would probably start lining them up because they're going to size up anyway. So you can probably do central line A-line, femoral central line A-lines, so that way they can size up for potential ECMO, and then continue with resuscitation from there.
Okay, so let's just assume that eCPR is not possible because of your location, right? Because we talk about time to like low flow state and no flow state and low flow state. Even though you've achieved minimal no flow state time, I mean the time that she was down, your low flow state time, even if you are doing good quality CPR throughout, it's going to be way too long for anyone who is doing the eCPR to get there. So let's just assume that it's not an option. You're not in an institution that does that. Mm-hmm. So, Jared brought up a really good point. You just brought up a good point as well, right? So you have someone in refractory VFib. This is the type of person that you think you're going to probably keep going until they are asystole or have no cardiac motion, right? Because when you stop CPR, you scan it with ultrasound, you see that she's still in VFib. She's not really responsive at this point because you've sedated her. But Jared brought up a good point, is I'm going to change the angle of my pads. Mm-hmm. Is that maybe, because what are the 2 things that we know based on evidence that works? Chest compressions and defibrillations, yeah. Right? And so in this patient, maybe I need to change the angle of my defibrillators, right? And so that's where the idea of dual sequence defibrillation comes in, right? And so it's a pretty amazing trial called DOSE-VF. And the idea is that I want to change the vector at which I'm attacking the heart, right? So you have your heart here, you put your pads laterally and anteriorly, and so it's attacking it in one vector. Let me also put one anteriorly and posteriorly and attack the heart from a different vector and shock the heart from a different vector. And so if you're going to do this, like Jared said, usually after that first or second round, if you suspect that it's going to be repeatedly VFib, you are asking for that second pad early on. Because in the trial that was done, people were already experienced with this because they practiced it. And they knew that on the 4th shock, they would be doing dual sequence defibrillation to attack, to kind of get them from. So both are charged to 200. one way to do it is that during the pulse check, before you ask for that pulse check, and Jared, if you're back here, feel free to chime in and interrupt me. Because obviously you might have had more experience than me with this, but before you interrupt the pulse check, advising the person to continue chest compressions until you're ready to go. You have one person lift the head up, one person put the back foot if it's not already there, and that same person, as soon as that chest goes up, slapping on that pad at the back of the chest, and as soon as they land, putting the pad on that other side of the chest, while making sure you're still leaving adequate room for CPR or for chest compressions. So this way you minimize the time that it takes to add those on and time off the chest, and then you continue chest compressions, you charge both devices, you make sure that one person is going to defibrillate both devices at once so they can actually synchronize it, because the idea is to go at the same time. There was a question in the trial that maybe they were a half a second off, and as you can see in that little small chart there, is that there was a significant increase in survival to hospital discharge by doing dual sequence external defibrillation. It's a great trial. I highly recommend doing it. The caveat to all this is that EMS and EM personnel who were doing this were trained and experienced on this. And so it's important that if we're doing it to replicate the success of the trial, is to also be trained and experienced with this. Unfortunately, I've seen this a few times and I've had the chance to do it a few times. And so far, I'm 7 out of 8 for this in trying to get someone out of refractory VFib, usually on the first or the second time we do dual sequence defibrillation. Do you guys have any questions or thoughts on this? And I don't know, Jared, if you're back or not.
He's still not back.
Yeah. What were we saying?
This might be worth a sin.
Yeah. So, I think it's a great piece of data for your refractory VFib patients, in addition to the amio, in addition to Lido. Let me ask you this. Are you guys still administering epinephrine?
Yeah.
So most of you are going to have an end-tidal CO2 on by now, and if you're getting good perfusion, there's some pretty good data, not good data, but there's some data that shows that if you are achieving good perfusion, and we know that when we're doing chest compressions, we're achieving good cerebral perfusion. So in this case, I don't think there's a need for epinephrine. I think you're just further mitigating the VFib, and on top of that, you're just causing a significant increase of severe brain injury. Because we know there is good data to support that in patients that you put on circuit for ECPR, the more epinephrine that you gave, the more harm that was done. So the moment you decided to do something like ECPR, there's no indication to continue epinephrine. If you're achieving good numbers in your end-tidal CO2, you're getting good compression, you're getting good perfusion with CPR, with chest compressions, you probably don't need the epinephrine. Now, once again, there's no evidence to support that, but yeah, go ahead. All right, so you've gotten ROSC, you've gotten her lined up, you move her to the ICU. While getting her moved, you were able to get you had requested an ABG. The labs are still pending in the ICU. 7.43, 39, 113, 26, lactate of 3.5. Exam, she's obviously less responsive. Her blood pressure is good. She's got strong pulses. Review of the course is that she was defibrillated about 6 times, including 3 with dual sequence defibrillation. Multiple courses of amio. She got the 100 of Lido. She also got only 2 of epi. Now you have her on an amio drip at 1 and a lidocaine drip of 4. You obviously look at the EKG. Oops. Are you guys able to see that or no?
Yeah, I was able to see the EKG. Looks like we have some SC changes in SC changes in what? The lateral is V3 to V6 got some SC changes, as well as V1, and then it's hard to tell what V2 is doing, but V2, there's a lot of concerning SC changes going on here.
Oh, wow, what do you think? I mean, Alok, what do you think?
I'm just seeing lateral in the precordial lateral leads depressions, as well as in lead 1, which makes me think like maybe something with the left circumflex.
Yeah, and so this is obviously these EKGs are very difficult to interpret, especially in this scenario for a few reasons. Number one being
AVR also is elevated.
yeah, absolutely. So one is that the patient had a cardiac catheterization today. So you have to compare it to the old one to see what's different. She had classic ST elevations in your anterior leads when she first came in. This is not what her EKG looked like after the cath. And so based on this, what I will say is that you see notable ST elevations in AVR. What that is it's until proven otherwise is a impending LAD occlusion at the proximal area, right? So your LAD branches off right near, right? You have your LAD branching off, you have your RCA branching off. And so because your AVR is pointing, so on me, if my LAD is going this way, my AVR is pointing this way, because it's at that proximal end, I'm going to see ST elevations in AVR and inferior leads in all my ST depressions in all my inferior leads. And that's what you're seeing here, and that's pretty concerning. It's a proximal LAD occlusion until proven otherwise, right? And she had a mid-LAD stent. So what are your next steps at this point?
Cath lab.
Gibson, you agree?
Yeah, I think individual cards need to be aware, especially because of the recent stenting. I think their input would be valuable right now.
Yeah, absolutely. So, right, like, I mean, I'm demanding a cardiac catheterization until proven otherwise. The cardiologist, you call the interventionalist on the phone, they're not very convinced, but they agree that given that she's in recurrent VFib, even in a patient that didn't have any prior stent, patient that recurrent VFib, I'm highly concerned for cardiac ischemia. You still have to rule out other causes, but this person absolutely warrants a cath, right? And some of the differentials could be, you've already ruled out tamponade, right? Which could have happened from the stent, distal migration, right? Which would, Jared mentioned that differential before, might be questionable because you're seeing more proximal changes, right? Or she could have a new occlusion, which would also be pretty scary because the person has been on dual antiplatelet therapy, right? And so you go into the cath lab, once again, the interventional is not very convinced. So
one of the other things is, when a cardiologist will tell you that when they stent, the places, assuming, I mean, this person is on dual antiplatelet, we can make sure, right? Regardless of that, it's the edges of that stent where there still might be some residual fat, where you're likely to have some sort of a buildup. And I mean, if it's mid-LAD and we're looking proximally, there could still be something that's not the stent's issue, but just right in front of it that could have occluded there.
Okay, all right. So she goes for a cardiac catheterization. Are there any other things that you would be getting at this time for your workup?
I mean, we know our cardiac enzyme is going to be elevated. If you want to get a CKMB, I'm not sure how much it's going to tell you at this point, because that's also going to be damage from defibrillation and CPR. So honestly, troponins, I'm going to look less highly at, and just I think basic labs like a chemistry. I think a chemistry is going to be a big thing.
Okay, why is that?
And CBC. Just to make sure there's no severe hyperkalemia.
Okay.
And no hypomagnesemia given the VFib.
Okay, right.
Yeah, I agree. Definitely check the labs, especially with this lady who's been getting Lasix. It was just in like VT, refractive VT, and then CBC. I think Dr. Ward mentioned a retroperitoneal bleed. I think a lot of that's still on the table.
Absolutely. So, she undergoes that repeat left heart cath. The stent is patent. It's in the mid-LAD. There's good distal flow. You see that there's a profound septal akinesis. She has on her echo that you're performing at bedside notable reduced EF, which is expected. She's got some profound septal hypokinesis or akinesis. Her ataxia maps here overall normal. Once again, a lot of limitations to that, and her overall cardiac output is pretty good. You have some of her labs there, CBC white count at 17, which is notably increased from before.
Potassium 1.7.
Sodium of 129, potassium of 1.7, mag of 1.8, glucose in the 240s. The X-ray shows that your ET tube and your central line are appropriately in place, and you're considering getting CT. You're just not sure if she's stable enough. So what are you guys thinking now? What's your approach next? All the interventionalists have said it's not due to occlusion.
Could she be having like vasospasms or something?
I'm sorry, Dr. Wab, you're not part of the risk case right now.
Oh, my bad.
Feel free to
Sure, I'm sure that could be a concern, but I mean, that low potassium is still concerning, so I would at the very least be repleting. I would double check that though. Yeah, I'd probably get an ABG as well, just to make sure, you know, from intubation says we're okay and we're oxygenating appropriately.
Yeah, we got the ABG.
Okay. Oh, that's right.
Gibson, what do you think?
Yeah, I think so. Every
Back
time
to the next step.
well, that sucks because we have someone who had like recent stenting and has like post stenting hypokinesis. That I don't know. I'm surprised she didn't get like an assist device or something to help with this septal hypokinesis and this reduced EF. Where are we? Is she requiring pressors at this point or what?
So her cardiac output is good, right? Her cardiac output is good, so she doesn't need an assist device.
You mean the LVTI is good? But
Yeah,
like,
they did a quick right heart cath. She's perfusing well. You know, she's got the reduced EF, but nothing to write home about. She's like maybe moderately reduced. She's got septal akinesis, which is the area where her infarct was. Could all be due to part of the area where her infarct was. But you know, she's perfusing well. She's not in shock. She's having good cardiac output.
Good. Okay.
Yeah, it's like,
Yeah, me too.
Besides the electrolytes, I don't have a clear reason for this. The bouts of BTAX that she had that was quite refractive. Yeah, I guess follow up this imaging.
So how much potassium are you gonna?
Oh, so for whenever someone's this low in potassium for me, they're getting both IV and PO. Replacements with Q4 labs until it's adequate. But yeah, at least 40 Q4 PO, and then IV without drowning them, also replacing 40 IV Q4, and then we're gonna have to recheck in 4 hours.
yeah, I mean, I know there's gonna be renal dysfunction, so I think I normally will split it. Like, you know, this person needs at least, well, they're below 2, right? So they're even below 3. Like we're depleted. Their store's already depleted. So I think with 100, I would be pretty comfortable giving. Probably even more, likely 150, and then reassessing.
So I guess how fast are you giving all that over?
In the central line, I think you can give up to 20 MEQ an hour safely. So I would probably place a central line and do that.
Okay. Gibson, do you agree?
Yeah, I agree. I agree.
So, you know, this is post coming back from the cath lab. You've started administration of the potassium. You requested that she get a total of 20 every hour for the next, I guess, 4 or 5 hours, in addition to labs Q4. And then you also requested that 40 be given orally, which will take some time to absorb. And so, you know, you go on, she's stable, you've updated the family. And so we'll quickly talk about hypoclemia and cardiac arrest. So, you know, just like you talked about, the recommendation is to give no more than 10 to 20 an hour. You know, you look at her, you know, why hypoclemia will cause an arrest. So we see that, you know, it's kind of like the opposite of hyperkalemia. This is the way I remember it at bedside, is that you see the classic U waves. And she did early on show those changes. And as it progresses in severe hypoclemia, then it can really precipitate, as you keep pushing down, can precipitate what is classically known as Persod's. And when you go back and interpret the tally strip, that's exactly what you were seeing. Okay, so in about 90 minutes, you know, I think in this case, we were just being a little more aggressive with the potassium depletion. And in about 90 minutes, in addition to the 40 orally, in addition to, you know, whatever we had given orally, she had also gotten 60 IV. because we were being a little more aggressive on the rate through the central line, just like you guys talked about. So unfortunately, you're in the next room. The 3 experts in the room are taking care of another patient. You guys are catching up, and then code blue goes off again, and you run back into the room. You see the phone, saying that's the same room. You run back in the room and you see chest compressions ongoing. The monitor was left in place, and now she's in VFib. What are your thoughts and what's your approach?
I mean, probably calcium first, just to make sure we didn't overcorrect and keep it intravascularly too high. I'm not, I feel like I'm making it up. I'm not entirely sure, but I think calcium initially, and then mag as well, given the torsades code doses. So you're just pushing it.
You're just pushing 2 grams of mag.
Yeah, 2 grams of mag, and calcium chloride at least 1, and ACLS.
Gibson, what are your thoughts?
Probably bicarb too.
This lady's giving me a run for my money, but yeah, I think the calcium's sure. I have nothing against it. But we're back in the VFib algorithm, so it's kind of just like I probably would have shocked her, to be honest. If she's back in VFib, I probably would shock her again.
And are you doing dual sequence?
Yeah, I'll after proper training, I'll probably give it a try.
Okay, so you're gonna basically do everything again for VFib arrest. You're gonna do dual sequence defibrillation. You're gonna keep on you already have on MU at 1, you have on Lido at 4.
Over max.
Yep, and then so you're going to be, obviously she's in recurrent VFib at this point. Anyone else have any other thoughts? You guys can just type in the chats.
Can you go back to the old EKG? There wasn't any miss QT prolongation or anything like that. QT looks a little long. I don't know. Probably stop the amio.
So I guess the question, why would you stop the amio?
I know they argue for and against it, but I feel like, if the amio can prolong the QT, and it's questionable QT prolongation, then having that running isn't really helping. It's already in their system, so it is what it is, but I don't want to add fuel to the fire.
Yeah. Rob says he was present for this. He cannot comment, but he did have some good thoughts earlier, is that not that this should preclude you from using dual sequence defibrillation, but apparently somehow voids the warranty on some of them at the hospitals. And so they specifically restrict the use of this. And that Stanley is very impressed that the patient got to the cath lab and had a repeat cath done the night before her labs even came back. And in this case, this was absolutely true. The labs actually came back during the arrest. And then the interventionist agreed that she should have gone to cath, but said once she saw the potassium that she likely had recurrent VFib arrest, likely due to the electrolyte abnormality, and to aggressively replete that. So it's important, right? Do we have any repeat labs since we started electrolyte depletion? She got 60. She went from 1.7 to 2.6. And so she's still at 2.6, and you're trying to replete as aggressively as you can. And so, I'm curious to see, Jared, are you back?
No, he's still not back.
Okay. So, which is okay because we have 2 expert resuscitationists taking care of the patient, but you've ran things by your attending, and so what ended up happening in this case, and it's a very difficult call to make because you think that you have a very survivable patient, and so when you think about reversible causes, and in this case, if you assumed that when your H's and T's, hypoclemia is a reversible cause because it can, like we talked about, precipitate cardiac arrhythmias. And it can cause, notable dysfunction in your cardiac conduction without diving into too much physiology. And, it's kind of important to recognize that as a cause early. So identify why she's so hyperkalemic, and her possible risk factors. And in terms of management, right, we're going by guidelines here. And I think it's important in this case to step outside a little bit in guidelines. And so what we did in this case, truly believing that the potassium was strongly the reason for her recurrent VFib, you look at what we could have done, and in some case studies where potassium has been attributed to this, is that putting a patient on ECMO, which is not a consideration here, just to really buy you time to replete potassium, so that she doesn't go out of ether. So then that time that you have her on circuit, you don't have to worry about her going back to refractory fit. However, in this case, it's not a scenario. And what we did was we looked it up on the phone at bedside and found a couple papers that supported more aggressive repletion of potassium. And despite being on the phone with pharmacy explaining what I'm trying to do, they refused again and again, and they kept canceling the order. But I told the nurses to put my name down and then go ahead and administer 2 milliequivalents of potassium over 2 minutes, and then follow up with 10 milliequivalents of potassium over 5 to 10 minutes. And the reason being is because I really felt that the potassium was the reason why we likely underlying cardiac dysfunction or underlying electrical impairment of the conduction system, that the hypokalemia was causing this impaired electrical system to continue firing and throw her into a tachyarrhythmia that was not allowing her ventricle to properly perfuse. And so we administered potassium a little more aggressively, got ROSC, and at this point, she still has a great exam. Even when you're trying to assess her for TTM, she's very responsive, she's suffering, she's struggling, she's in a profound amount of pain. The entire family is horrified by how uncomfortable she is having to witness, throughout that CPR. Obviously, we're telling the family that we think, that at this point we're concerned about her. They're seeing her, they're wondering if you should stop, but you got ROSC by giving a little more extra potassium. That's exactly what happened. So you've discussed everything with EP, that you're concerned about an underlying arrhythmia, and their concern at this point is that she's a poor candidate for intervention. And so I think at this point, and this is where, if we had any of the attendings on who have a lot of experience with this, I would be kind of like, requesting one of the attendings to chime in. But at this point, what is the discussion that you are going to have with the family regarding the what's going on and what your plan is? And maybe Gibson, you might go ahead and give this a try. Pretend the family's here, and what exactly are you going to say to them?
So based on what we believe to be causing, I probably would just kind of let them in layman term as much as possible. Just kind of, hey, besides the initial reason needing the stenting that brought her into the hospital, she has a significant electrolyte abnormality that's causing her heart to go awry. Our plan from the ICU stand is to aggressively replete that and hopefully retain and continue normal cardiac activity, and just acknowledging, I think in the ICU it's very important to acknowledge that all the patient suffers, family members also, suffer along with them, and try to at least give some comfort and, explain the plan as clearly as possible.
So how would you kind of bring things up with the family? What would be your game plan now?
If anyone's heard me talk to family, I always start off with the same thing, which is always to see what their understanding is of what's going on first, and make sure, they talk them through the events that had just happened, and make sure they understand what is going on and why it's going on. Because I feel like that really affects further decision making. And so obviously they're gonna be horrified because all they see is the gruesome parts of this with blood spewing everywhere. But there's a rationale to what we're doing. So see what that is first. If they're not a candidate, explain that part, and then see and then explain to them what the options are going forward. I feel like in these scenarios, there's always going to be a question like, well, can we get a second or third opinion? Like, yes, you can. It won't be in-house in this scenario. So we would have to be reaching out and see if that's an option. If it's not an option, then lay that out for them as well.
Yeah, really excellent points, and I'm sure that Stanley brings up a really good point, addressing goals of care. And in these cases, it's very tough, at least in from my perspective, and based again on the evidence and real life instances, is that you don't give up on patients with these VTAC or VFib until you have to, because majority of the times it's something that you can address, right? Maybe the heart has just given up. At that point, you have to admit that. But in this case, you've explained things as well as you can to the family. You've also explained that You've also explained that electrolyte depletion, how aggressively you administer the potassium is a very unorthodox thing you're doing. It's a very high risk thing you're doing. You obtained permission from the family to do it, knowing that what you may do may actually make things worse, but you have nothing else to offer. And so that's how we kind of administered that potassium that fast. And obviously in this case, written up for it and everything, but attending kind of backed me up on this. The family also kind of gave consent for this, and we documented all this in a lot of detail. They're very grateful that the patient has achieved ROSC. And at this point, because of your strong conviction that this is due to an underlying rhythm, to kind of go along with what Rob said, is that aside from ACLS during this entire situation, is there anything else that can be causing her to be in recurrent VFib aside from the electrolytes? I think that's absolutely true. That in this patient who you are depleting potassium is likely a secondary factor to something else. And given the concern that it's an electrolyte, an arrhythmia issue, she may be a candidate for ablation. And obviously, trying to push for that to be done because you've done the best you can. You've achieved stabilization. The patient looks stable. She's obviously in a lot of pain and a lot of discomfort. And maybe if you can address the ablation, she can survive. So, I think, Rob, you took care of this patient. Maybe you want to fill us in on what happened, including the call to Penn, her transfer. And I know you spoke to the EP over there and exactly what happened after she got there.
Yeah, I can. So afterwards, after Uday did all his hard work for his shift, she finally stopped going back into VFib. We called Penn Transfer Center for an EP evaluation and emergent transfer over there. So I was able to send over strips, and let me see what he wrote. He said, let me see, give it. He says, I wonder if pacing will help initially. And he thinks maybe there's like polymorphic VT after like a kind of like a short interval is throwing her into it. His concern was that it was an irritation of the fibers after the stent placement that was causing her to go into refractory VFib. And this is somebody who would benefit from like an emergent ablation, as Uday was alluding to. Unfortunately, we did get her over to Penn, and she did okay, but initially, but she had to go through the entire EP. I guess they had a meeting in the morning as far as discussion, given her recent stent placements. Overnight, she actually developed worsening hypotension requiring multiple vasopressors. And she also had like increasing oxygen requirements. And it kind of precluded her from going to the EP lab right away. The electrophysiologist's hopes was that he would get her transferred that day and emergently next morning get her ablated. But because of the vasopressor requirements and increased oxygen requirements that she had, she sustained another VFib arrest the next morning after transfer, and unfortunately couldn't get her back. But he said that it's in his world, so in the electrophysiology world, there's rarely ever a case where a patient or anything, it requires emergent ablation. And he said this is one of those very few rare scenarios that does require emergent ablation.
Awesome, thanks, Rob. So, really, really tough case. I think a really great learning case. Gibson, Alok, Jared, excellent job. Jared, you with us?
Nope.
I will say
He's
though,
there, that's all
just
that matters.
kudos to like
He was having
Uday
a
and stuff
difficult
and the
time
team
with
overnight. After speaking with the electrophysiologist, he did kind of give a big kudos to like the Inspira night team and Uday for kind of doing everything. Because even there, they had, after she went back into the VFib arrest, had difficulty trying to get her back. So huge props for that.
Thanks, man. I think Gibson, you were about to say something?
Man, definitely a great learning case for sure. That I think the learning points that were touched upon are like high yield and just a good reminder. Definitely remember hypokalemia on my next VT at rest.
Awesome. So just some really quick pearls. We'll kind of fly through it. You know, there are a lot of great protocols out there. CASA protocol, CAUSE protocol, POCA-CA protocol. They have great diagrams on how to approach ultrasound during a cardiac arrest. You'll go through all of them. You'll practice them, and then you'll continue to modify it on your own. You know, I think it's important. Record these clips. Don't waste time doing CPR. I see too often that mistake being made, and the time off the chest continues to get delayed more and more. Be aware of C-prick. It's horrifying to see. We had a patient who had a swan in place, kept getting up during the swan kept tickling the area, and then they kept throwing him into VFib. And then you would do CPR, they'd wake up and you have this huge 400-pound guy that you're trying to control. And in that case, we also gave ketamine. And that was my first time seeing it. After that, I said, I never want to be unprepared for that situation again. Don't just perform routine CPR. You guys are experts now. Get someone else who you trust to do CPR, and you guys focus on the things that matter, addressing reversible causes. And that includes airway, right? Once you get your experience with intubating, just learn how to put an LMA in, or let the anesthesiologist intubate while you focus on things that matter, that you are an expert for. Consider use of dual sequence external defibrillation, but you have to know how to do it, and you have to ask for that second device early, keeping in mind that if you're at somewhere in Vineland where they have multiple ICUs, there's only one per floor, and if I'm seeing VFib, by the second one, I'm asking someone to run down and grab the second one. ROSC is not equal to resuscitation, right? Just because you have achieved ROSC, your job does not stop there. In fact, that few minutes after ROSC are some of the most crucial minutes in the patient's course afterwards into preventing them from having another cardiac arrest. It's challenging, but extremely crucial. We've already talked about this. If it's electrolyte deficiency, replete, recheck, replete, recheck. In this case, we were doing BMPs every 10 minutes and using our ABGs as a surrogate for where the potassium was. And guidelines in this case are just guidelines, but you have to back up your plan with reasoning and evidence if you decide to veer off those guidelines. And if you decide to do something crazy like push 2 milliequivalents of potassium in 2 minutes and 10 over 10 minutes, 2 more over 10 minutes, then get permission from the family and be able to back it up, because you will get written up for it. Don't delay early central access. Don't delay that A line. It's providing you way too much information early on. It's a procedure that you guys are good at. Even in the worst cases, having this thing in early is going to allow your resuscitation to go a lot better. And then we talked about, right, in this case it's important because you needed faster depletion of potassium. You can't do it peripherally. Unburden yourself from making these tough decisions, right? Like all of you guys have talked about, involve the family in the decision, informing them in the most basic terms of what's going on, what you can offer, so that they can help make that decision. And then, ignore that last one, I didn't change it yet. But, if you are truly advocating for your patient and a consultant gives you advice that you may not necessarily agree with, seek out additional advice. You can also seek out a second opinion on behalf of your patient. It doesn't just have to be from, the patient. It can be you as advocating for the patient, especially this one who is this appearing overall somewhat healthy after, 2 pretty aggressive episodes of CPR. Once again, guys, great job. I'm very glad that the patient had you guys on service to take care of her. And that's all I have. Anyone have any questions? All right, cool. You guys will take a 5-minute break and then a while you're up.